Welcome, my name is Savannah Bailey, and this is my comparative effectiveness research investigation. We will be comparing static stretching and muscle energy technique. The objectives for this presentation are to discuss the conceptual framework for the condition of interest and the interventions we will be evaluating, examine the clinical plan that has been created for the investigative comparison, and address the clinical significance and feasibility of implementing this investigation at the point of care. The condition of interest is a hamstring tightness or general inflexibility by hamstring musculature. A muscle becomes gradually or acutely tight as it is unable to relax or recover between activities. This tightness can elicit muscular spasm, decreased joint range of motion, and pain. Many sports require running in order to participate successfully. Running frequently hypertrophies the gastrocnemius and hamstring muscle groups, with concomitant inflexibility of these muscles. Clinically, muscle tightness is believed to be an important cause of injury. The first intervention is static stretching. Static stretching is a technique that affects both the contractile and non-contractile tissue of muscles. It is the positioning of a segment at its barrier and then allowing gravity or an external force to stretch the muscle tissue over a significant length of time. That external force could be a clinician or a stretch strap as an example. The muscle is elongated to tolerance, which is key. The stretch must be comfortable and not painful. Most literature supports that patients should hold the stretching position for 30 seconds at a time. Benefits included following static stretching are that this prevents the tissue from having to absorb abundant amounts of energy, the static stretch will not elicit a forceful reflex contraction, and this technique can alleviate muscle soreness. The second intervention is muscle energy technique. Muscle energy technique, or MET, is a manual technique created by osteopaths employed in athletic training to lengthen, shorten, or contracted muscles. It requires the patient to create a force by activating the targeted musculotendinous unit against a specifically guided counterforce applied by the clinician. It is followed by relaxation and a passive stretch also applied by the clinician. Benefits included following the use of MET are restoring normal tone in hypertonic muscles, strengthening weak muscles, preparing the muscle for subsequent stretching, and improved joint mobility. Both static stretching and muscle energy technique have been compared against other forms of stretching such as PNF techniques and ballistic stretching. Static stretching has been identified as a more common technique over ballistic stretching and PNF techniques. MET has been found as a better technique in improving hamstring flexibility when compared to ballistic stretching and is also considered more efficient than PNF stretching. However, little to no comparisons have been made regarding whether MET or static stretching is superior and their influence on hamstring musculature. Therefore, the clinical question is as follows. In physically active individuals with hamstring muscular tightness or general inflexibility, will static stretching compared with muscle energy technique be more effective at reducing pain, improving active range of motion, and improving patient-reported levels of function? Comparative effectiveness research comprises of both the synthesis of existing evidence and the creation of new evidence that compares alternate approaches to the prevention, diagnosis, or treatment of a health condition. As defined by the Institute of Medicine, CER will assist consumers, clinicians, purchasers, and policymakers to make informed decisions that will improve healthcare at both the individual and population levels. Randomized controlled trials are considered the gold standard of efficacy research. They are also the cornerstone of CER. Therefore, it seems appropriate to gather this information using a randomized controlled trial research design. Subjects will be randomly assigned to a group and matched upon initial test scores. This will attempt to ensure heterogeneity among the groups. Subjects will meet 3 days a week for 8 weeks for their treatment intervention. The patient population is described as physically active and will be defined as running more than 1 to 2 miles 3 days per week, athletes who participate in organized sports, or those individuals currently enrolled in guided military training iterations. These will be the only inclusion criteria, and the only exclusion criteria will be the history of prior hip or knee surgery. The MET treatment will be applied using a post-isometric relaxation technique. A clinician will passively flex the hip until resistance due to hamstring tightness is felt. Then the subject will apply a downward pressure to the clinician's shoulder for 10 seconds while keeping the knee straight. Finally, during the relaxation phase, the clinician will passively flex the hip until similar resistance is felt. That final position will be held for 30 seconds. The subject will have 10 seconds of rest and the stretch will be repeated 3 times. The static stretching treatment will be 3 repetitions of 30-second holds using a non-elastic stretch strap. The subject will be instructed to keep the knee straight and all 3 repetitions will be followed by 10 seconds of rest. The participants will be instructed to stretch both legs. The visual analog scale will be used as pain. It will be a 100 millimeter straight line, and the subject will mark on the line corresponding to their pain level. 0, no pain, and 100, unbearable pain. The VAS is easily administered and has been found to have a high rate of reliability when measuring pain. The sit and reach test is a common flexibility test used in health-related fitness test batteries. This test has acceptable reproducibility, moderate validity, and is easy and quick to administer. It will be performed in concordance with the ACSM manual by placing a standard sit and reach box on the floor, the arms extended forward, placing one hand over top of the other and palms down. The subject will reach forward, placing hands along the measuring scale as far as possible without bending the knees. The average of 3 trials will be recorded. Finally, the LEFS is a self-reported questionnaire used to assess patient function that has been proven reliable, to have acceptable construct validity, and to be sensitive to changes in function of the lower extremity. It is important to remember how to determine what is an improvement based upon the outcome variables that have been chosen. A mean reduction in 30 millimeters represents a minimal clinical difference in pain severity. The sit and reach test values will be compared on a parameter of percentage improved, since no current evidence reports clinically important or meaningful values. The minimal clinical difference for the LEFS is 9 points. A change of more than 9 points represents a true change in the patient's condition. The minimal clinically important difference for the LEFS is also 9 points. Clinicians can be reasonably confident that a change of greater than 9 points is a clinically meaningful functional change. These outcomes will hopefully provide adequate data in order to answer the clinical question of discerning which stretching technique is superior regarding hamstring tightness and inflexibility. The findings from this study have the ability to impact clinical practice within athletic training in a number of ways. Determining which treatment intervention is better suited to increase flexibility, decrease pain, and dysfunction will directly affect which intervention an athletic trainer will implement. As a result, implementing a more effective treatment will improve the level of care. If static stretching is determined to be more beneficial, then this could afford athletic trainers more hands-on time with other patients, instead of that time being devoted to MET of the hamstrings. In addition, it will provide patients further incentive to perform this intervention more often independently, because they are aware of its effects. Alternatively, if MET is determined to be more beneficial, this may afford athletic trainers dedicated hands-on time with, which may strengthen the clinician-patient relationship. However, MET requires the knowledge and skill of the clinician. Therefore, the clinician will need to remain proficient at this technique. If both interventions are found equally beneficial, then it will be left to the clinician to determine which to implement. Quite possibly, the clinician could perform MET treatments and then instruct the patient to perform static stretching as a part of their home exercise program, because it has been determined that both are equally effective at achieving the reported goals. If neither intervention is found to be effective at the measured outcome variables, then the clinician will be left to innovate another technique, which has the potential to proliferate the profession of athletic training, or the clinician can continue to implement the intervention of their choice based on anecdotal evidence and experience. Conducting a randomized control trial can be laborious and time-consuming. Therefore, the selection of tools that are easy to administer and simple to score can be very helpful. Implementing this randomized control trial at the point of care should not be too arduous a process, as static stretching can be performed without assistance and oversight, and MET will require no more than 45 minutes per subject. This, coupled with the relatively short amount of time required for the completion of the VAS, sit and reach, and the 2 minutes reported to complete the LEFS, indicates the temporal demands on the athletic trainer will be low. Once results have been aggregated, the findings will be shared with all relevant stakeholders in order to successfully disseminate the information. Members of the public, such as patients, coaches, and parents, and healthcare providers, are all considered appropriate stakeholders regarding this randomized control trial. The results can be shared by printed documents within the healthcare clinics or posted on athletic fields. In addition, there is a global email server on the base of Marine Corps Quantico that will directly contact healthcare providers, in which the lead investigator will send out the investigation results. Thank you for listening. Stay warm.